Hello and welcome to Promise Videos. Today I want to introduce you to some ideas put forward by Dr. John Kelly, who is an Associate Professor of Psychiatry and Addiction Medicine at Harvard Medical School. Last year I saw he gave an interview to DrugFam, and I thought he made some really important points which I want to share with you here. In particular, he was talking about how careful we should be in the language that we use when describing addiction problems.
When it comes to very stigmatized conditions, we have to think very carefully about the kinds of terms, it turns out, the kinds of language that we use and the terms that we use to describe the conditions and the people suffering from them. And this is because there are certain terms that can actually lead to certain sequences of, trigger certain sequences of cognitive scripts, which result in attitudes and actually biases.
Okay.
And we have found in studies now, several studies have found that certain terms actually induce these, what we call implicit cognitive biases, which means unconscious biases. So even when we're not actually aware that language may be triggering a certain attitude, we find that this is actually the case. And it turns out that certain terms in the addiction field can do this. Back in the 1970s, for example, the World Health Organization explicitly said, better not to use the term abuse because it can lead to other kinds of stigmatizing terms like abuser, which is associated with even more stigmatized conditions like being a child abuser.
Right.
Or socially discrediting attributes or behaviors like being a child abuser. So it actually says, we shouldn't really use the term abuse, but unfortunately, the term abuse has become very commonly used with substances, with substance use, right? We often hear the word a drug abuser or an alcohol abuser, an alcohol abuse, drug abuse. And it was actually adopted in the United States by the Diagnostic and Statistical Manual. This became a part of the nomenclature in that diagnostic manual in a few iterations ago, so that the term abuse actually was incorporated as part of the official lexicon of psychiatry. Okay. And also in the United States, we have our National Institutes of Health to do with alcohol and other drugs are actually called the National Institute of Alcohol Abuse and Alcoholism,
right?
The National Institute of Drug Abuse. Okay, so it's embedded in our culture and in our lexicon, and people have been kind of upset about this particular term because it implies that the term abuse implies this aspect of willfulness or willful misconduct.
Right.
But depending on where you're coming from, of course, if you're coming from a kind of a more of a punitive war on drugs standpoint, then that kind of fits, right? Because if you want to scare people off and stigmatize it, then you want to call people abusers because they're engaging in willful misconduct. They have the ability to refrain from it, but they're not. They're choosing to do it and therefore should be punished. And if you think about it, if you think about other disorders which are similar, kind of first cousins of substance use disorders, like eating disorders, right? If you think about someone with an eating-related problem, we almost uniformly refer to that person as having an eating disorder, not as a food abuser. But when we talk about drugs, then we uniformly refer to that person as a drug abuser, not as having a drug use disorder. It's very important that because our language really, it both reflects and influences our approach to how we treat or address these conditions or social problems, or whatever we want to refer to them as. How we frame it, how we talk about it affects our approach, right? It reflects and affects our approach. So if you describe the phenomenon as substance abuse and individuals engaging as substance abusers, then that has a potentially different connotation than describing these problems as substance-related conditions and individuals who suffer from them as having a substance use disorder.
Okay.
Right? So you can think about the different kinds, if you would ponder that a little bit, what would mean if I called someone a substance abuser versus having a substance use disorder?
Right.
Right? Is there anything different that might be conveyed or understood by someone hearing those terms? And we actually did a couple of studies exactly asking that question. And we exposed about 600 doctoral level clinicians. So these were people working in the addiction and mental health field.
Okay.
We randomly assigned half each of the audience, half of them got a vignette describing exactly the same person who's in trouble with the law because of drugs, and describing them either as a substance abuser or as having a substance use disorder. Otherwise, they were identical.
Right.
And then, so we randomly assigned these vignettes to 600 doctoral level clinicians, and then we asked them to read it, and then asked them questions about, was this person to blame for their problems? Should they be punished? Should they be treated, etc. And what we found was that people at random who were well trained were, when they were exposed to the term substance abuser, they were more likely to view that person as to blame for their problem and more in need of punishment, less in need of treatment.
Okay.
Compared to that same person described as having a substance use disorder. We also replicated that in a sample, a general population sample, did a similar study. We found even bigger differences than those among who are in the clinical sample. So when you expose people in the general public to these terms, they're even more likely to view a person described as a substance abuser as being more in need of punishment and less in need of treatment and more to blame for their condition. We actually have some experimental evidence here that actually shows that when you expose people, even well-trained clinicians, to particular terms, in this case, the abuser term, it actually induces an implicit cognitive punitive bias. So to the extent that we want to minimize that kind of punitive bias and move towards more of a public health model, we might want to say, let's get rid of the term abuse and abuser. Let's stop using abuse and abuser completely. Let's remove it from the lexicon. Let's remove it from our vocabulary when we describe drug-related conditions and people who are suffering from them. That would be the first thing I would recommend. The next thing I would recommend, and this has really been done in the mental health field, way ahead of the addiction field, which is to use person-first language, so-called person-first language. So in other words, instead of describing someone as an addict or an alcoholic, but rather to describe them as a person with or suffering from addiction or person in recovery from. So in other words, as they've done in the mental health field, we don't describe people ideally anymore as being a depressive or a schizophrenic, but rather a person with schizophrenia or a person suffering from schizophrenia or a person in recovery from schizophrenia. And in the same way, it's recommended that we use similar person-first language when we're describing individuals with substance use disorder. That's not all of who they are. It may be extremely important and it may be the top priority to remember who they are, because that's a life-saving phenomenon to recognize that you're a person who has that disorder, but that doesn't define the whole person. So in the same way with someone with schizophrenia, it doesn't define who they are. They are still a person separate from that illness. In the same way, the same is true also of individuals suffering from substance use disorder. Another thing, Marty, is just the term that sometimes is used. We know that it's used in among individuals themselves in recovery, and that is kind of clean and dirty.
Okay.
But what we found also is that even in clinical settings, sometimes urine toxicology screens are described as clean or dirty. And I think, we don't use that kind of rhetoric or language in any other area of medicine. And I think getting away from language like clean and dirty, certainly in clinical contexts, we want to remove that from our clinical lexicon and language, and describe those kinds of test results as positive and negative, the way we would any other kind of test result, instead of clean and dirty urines or clean and dirty blood tests, etc. So that's another. So those three aspects in terms of getting rid of the abuse and abuser term, using person-first language, and also getting rid of the clean and dirty aspect of drug use.